We have about what I would expect be able to join us. So I guess first off, just to open the floor to the group, I wonder if we could just quickly go through who we are, where we're located, and connecting to that first question that I had put in the box of like, where in your work does the IHD resonate? I recognize that not everybody will have read the whole report. It's, several dozen pages as well. But I wonder if you could just speak to even just hearing what Dr. Crochet and I spoke about, our process, the principles that kind of undergird it all, and the ideas of leadership and what it takes to shift our institutions, how we can work with external directives to achieve things that are big visionary sort of asks of us. So I will just decide that we can follow that process to start with. We're 8, so I'll just ask each of you as I see you in a circle on my screen. So I wonder if we can start with Dr. Friedenreich.
Hello, so I'm Christine Friedenreich. I'm currently the Associate Scientific Director for the O'Brien Institute for Public Health. And I've had the great pleasure of meeting with our group on research in Indigenous persons, which is part of the O'Brien Institute.
Focused on research. So I'm looking specifically at how the O'Brien Institute can help build capacity in Indigenous faculty members, in the funding they get from research agencies, in the support that our various research support staff can.
Barbara Brownlee.
So I'm Senior Administrator of the Alberta Children's Hospital Research Institute. I echo a lot of things that Christine mentioned as well. ACRI has an education platform whereby training is in our portfolio. And so I was just curious to see, similar to Wendy, just to learn more. I haven't read the strategy either, and so I just wanted to know what the conversation is all about, so I could probably add a few things to our senior leadership and mention a few things that we could or should talk about.
Great, thanks. I'll put up the visual shortly after we go through the intro, so we can maybe engage with it more directly. Dr. Mansoulis.
Hi there, I'm Steve. I'm a family doc and I work in education and post-grad medical education. I'm the Director for Advocacy and Accountability. So part of my portfolio when it was, this is a brand new position and unique, I think, among medical schools. It was actually focusing on Indigenous health and particularly around how we would institutionally respond in postgrad around the calls to action. And so I have worked previously with, with Rita and Elaine and Lindsay on some of these topics, and was the beneficiary of possibly seeing a sneak peek or two of the documentation. But I will admit that I am going back and rereading and doing everything again from scratch now that everything is formatted and glossied. And every time I do so, I find that I learn more. As far as the stuff that's really sort of jumping out at me, obviously, I think that along that education row, I think that is certainly it. And I think, the first two truths located within that education arm is really what speaks to me, and trying to figure out how it is that we're going to respond to those things. So obviously, the truth around that we need education, and then the second being that what we have right now is inadequate. And so need to work on those areas for sure. And that's what I hope to be part of the solution around PGME wide, not just in family medicine, which is where I make my home.
Quick question before we move to the next. When you say not adequate, it's in there, but where do you see the inadequacies?
Well, I think that there is an awful lot of, I think there are a large number of programs, so the majority of which, if not almost all, that don't incorporate a meaningful and thoughtful discussion of Indigenous health issues as part of their routine core curricula. And I think that when things do come up, they are ad hoc. They may be potentially single shot. I don't see an integration. I don't see this being embedded. And I think that one of the things I think about is not just curriculum delivery, but curriculum reform. So it's not just about adding new things, because as a recovering program director, I will tell you there is nothing that a program director dislikes more than being told that you need to include more things in your curriculum in an ever shrinking, time frame. And the crushing realities of that COVID have created around delivering educational things as well, I think is part of that too. But I don't see a thoughtful everyday integration of Indigenous health issues. These are often things that are expected to be dealt with big flashing lights, and this is our Indigenous session, and this is going to be and as opposed to how do we talk about these things on a day-to-day basis, and how do we integrate this on an ongoing basis within our curricula.
Thanks for clarifying that, because I think we'll come back to that when we're thinking about what you've just talked about challenges, but we can maybe identify opportunities and maybe what structures are needed. I see this. I'm the lead in O'Brien Institute for GRIP. I have ideas about what are how we could be more cross-cutting, but it is also a struggle for me to figure out what are the structures that are lacking that I need in order to be able to do this better. Next, Kavya and Churi.
Great. It just took a second to unmute. I'm just a medical student in second year at University of Calgary. I've read through the main campus's Indigenous strategy, the Together in a Good Way. I don't know how to pronounce it. Sorry. So I've read through that, but I'm just looking through the dialogue right now.
Thanks. And they're actually, the dialogue tries to connect to the larger university etopo strategy. I think what really opened my eyes with doing the IHD process with Dr. Croshu was that as we were doing it, the main campus was also working on theirs. And I remember thinking, are we spinning wheels? Why is it that we're doing something? And what I really discovered was that there is just so much context in medicine. There are so many elements of our institution in medicine that we have to go into all of them and explore what can be done. And so I do think that there's an immensity in our institution that invites us to have a unique approach. Not even a unique approach, just an aligned approach that just we want to be supportive of everybody in a longitudinal fashion to keep taking up this.
For sure. Exactly.
Dr. Boyling.
Hello. I'm a researcher at the University of Calgary. Yeah, I've been lucky enough to sit in on the dialogue since it started, and it's just my big reflection on it is how exciting it is to hear people coming up with realizing how real, and while it might be complex, it might be tricky, this is real stuff that we can really do, especially if we're working together on it. And I think it's really, really exciting. It's been exciting getting to hear so far, and I'm excited to hear what comes up today.
Thank you. So something that I heard it in the mention in when Christine mentioned the medical education component in O'Brien, and I heard it a little bit in just training mentioned by Dr. Brownlee. So I'm going to bring up I'm going to share my screen for our critical reflective diagram to think about it. 23 or 24 of the TRC asks for all health professionals to have a course in Indigenous health with certain components like anti-racism education, conflict resolution, and like knowledge of treaties and international and local laws like the UN Declaration. I personally have found that to be insufficient. I think it's important that we have a high performance group of people that can take advanced training in and these things. But I actually think a lot of those components could be embedded in all sorts of activities that we do in our institution that are outside of a graduate course, because we have hundreds of people that need to connect to this knowledge that aren't taking graduate courses in community health sciences. So here's the quick, what are the challenges in doing that immense kind of training? Like, how do we get everybody to connect to that kind of knowledge? What kind of opportunities should we ask the institution to support? And what structures do we require to do that? So I'm just putting that out there, thinking that we may have like 5 minutes left to talk. Any quick thoughts?
So Rita, I have a quick thing to ask. So my primary appointment is with Alberta Health Services, and all AHS staff are required now to do an Indigenous awareness training, and it's I think it's a 7-part training that we've all done. So I don't know, has the Cumming School of Medicine or the University of Calgary more broadly thought of putting together some sort of an online program like that all staff and faculty and students could take?
Well, as an answer, for one, that training is obviously very helpful, some good contacts. There's some critical advanced perspective that we would like to push further, like getting at anti-racism, structural competency, and things like that. Certainly as like an entrance point for knowledge, that is good. There's also a MOOC, like one of these massive online courses at the University of Alberta that I'm encouraging the Community Health Sciences department to maybe get undergrads to take, or their graduate students to take. Yeah, it's excellent. And yet it doesn't go far enough to be like leaders in this area. And Dr. Croshoe actually leads an initiative called Educating for Equity. But it's happening as a research project that we're doing, and it's been years in the making, but we're adapting it to online. But it's really a tool for family doctors to shift practice. I think there's a sophistication to it that hopefully we could get to institutionalize, but it's only emerging because of the research commitment on the part of the team. And so there's like modules and stuff. So yes, online training is excellent, but also thinking about like the different places different people are at for learning is a challenge. And I guess my caution is, or my fear is, that Lindsay Croshoe has made educational things for years that are funded through project schemes and then wind up on a shelf because there was never that capacity or willingness on the part of the institution to find a way to mobilize it internally and make it more standardized. And so, part of today and part of this series is we don't expect to have the answer today, but we want to be able to talk about these things so that those of you who come and join us can say, oh, but we just didn't have a relationship, but we could totally find a way to mobilize that over here. And that's what we hope to nurture.
I know from some people who've taken that AHS training that it really, like, from what I've heard from people who've taken it, that it falls short of where it needs to be, and like is just one of those trainings that people click through and might really like pay attention to if they don't want to. So that is really important. And like if there's I've heard such good things about the MOOC at the U of A, like a lot of like prominent Canadian figures who are like encouraging people on Twitter even to like engage in it and take it. And I wonder if there's like a way to like make that like mandatory for all health professions, students, like at the Cumming School of Medicine, or like some version of that.
Here's another question that's drawing off of that comment, is to what extent does making things mandatory help? We heard as we were doing the Indigenous Health Dialogue, time and again, we were told, just like I think you were suggesting, Steve, is that when you're told to do more, it's just hard. It's so impossible. So I guess it's just this question of how do we, like, do we mandate this? How do we embed this? How do we create a culture of just doing something super high performance? What are thoughts here? I wonder if anybody else is getting stirred with any thoughts.
So one of the things that I think helps in these contexts is external accountabilities, not just saying that this is a thing that we're going to do because we think it's the right thing to do, but doing something because it is an actual requirement, and the higher up you can create that mandate, the more effective that can be. So, for example, if something is happening because it's an AHS-wide initiative within AHS, I mean, everybody has an understanding that they're doing that. If something's happening at the Cumming School of Medicine in order to do something because it's part of the strategic plan, then there's a mandate for department heads or associate deans or whomever else to sort of implement that. But what really gets people going is accreditation. If you have a standard that requires this, and then people know that every so many years somebody's going to come around and open the books and say, what do you do and how good is it and how are you evaluating what you're doing? I think that tends to be an even more impressive driver. The pushback comes because there are so many additional similar simultaneous asks, and that tends to be it. So if you're asking somebody to do something because it's the right thing to do, it may get pushed below the threshold for the things that must be done because there are external accountabilities related to it. And so the more that you make something a requirement, that may be not necessarily sufficient, but it may be necessary in order to affect the next step in people being able to make those things happen.
And from medical school perspective, there's something to be said that like for the purpose of accountability and accreditation, we all have to learn 1 or 2 weeks of ophthalmology or something. And the extent to which that becomes useful in every med student's future career obviously depends on the path that they take. But something like Indigenous health is arguably more cross-sectional across all medical disciplines than is ophthalmology, I would argue. So really the attitudes around what is mandatory and what does get examined rigorously is just a construct of I think, again, this is all conjecture, but it's a construct of the way that the medical education is set up. So if we treat this the way that we treat ophthalmology, then no one will question that this is a mandatory thing that I have to learn and be assessed on and gain some competencies in order to become a competent physician or healthcare professional.
This is interesting, and I think everybody here is really echoing this. I'm making the linkage back because I helped author the report to that idea of Indigenous health as its own discipline, thinking about it as a knowledge set that cross-cuts all of medicine as population health and nature, but it needs some formalization in order to be recognized as having a certain place and where it exists and why it's a knowledge that everyone needs to somehow connect to. And so I'm just aware that we should probably get going back into the group, and we might get dumped into the larger group quickly once it, or is it gonna, are you doing that, Lindsay?
Everybody, if you can just select leave room, and then in about a minute, I will close all the breakout rooms so we all return to the large group.
Okay.
So
Thanks.
I just want to have one final thing to say to you. Yeah, I think that you're going to need a multi-pronged approach at different levels. And so when I was saying that, across the board, you could do something online, but obviously you can go much deeper if you embed it into the curriculum, if you make it part of accreditation, if you make it part of, everybody doing research has to have some training now in unconscious bias, right? So it would be like a required program. So making it a requirement is probably what you're going to need to do, but you will have to come at it from different angles because you've got so many different kinds of staff and people and students and whatnot, and trainees working within even just the Cumming School of Medicine, let alone the entire university, right? Mm-hmm. But having a matrix of things that will hit most people, I think, is a strategy.
Wow.
Yeah, there's the opportunity to do things like that, and so you can do things that are those foundational moments, which then the worry always is that then becomes its own thing, and then because you can hold it up and saying, well, it looks really good on a glossy report every year. It says all of our incoming residents took did the massive online course or did whatever. The trick for me is using that as a foundational starting point of a shared basis of knowledge, and then integrating that longitudinally throughout 65 different programs, which starts to become much more difficult, because to have credibility, your leadership needs to be involved within each of those areas, because I, as a family doc, can't really go and talk to, I mean, we're picking ophthalmology, but, to the ophthalmologist or the otolaryngologist, for example, I lack credibility coming there without that clinical piece. So how do we develop something that is not necessarily bespoke, but that speaks to people where they're at? And by the same token, the same stuff that's going to work in the context of otolaryngology or ophthalmology might not be what works in community health sciences, may not be what works best in nursing school. There's many different ways of trying to figure out what that best delivery platform is. It doesn't mean we can't learn from each other, but maybe there is value in having a foundational piece to start from. One would hope that this would be, start to be embedded more deeply in earlier stages of training. But that's not the case. And we also then have to contemplate all those people who join us from overseas, for example, and making sure that people are entering into our system at any point and then still have a similar chance at getting this right. Because if people haven't talked about it before, we can't have the expectation that they're going to be masters of it yet.
Mm-hmm. It's almost like you need like a critical educational unit that can kind of fan out and support, but hold a core set of knowledge to help create consistency and alignments, and at the same time contextualize to each area. Yeah.
And I think just listening in today, I was in that, Lindsay mentioned just talking with Reg Croshoe earlier, and I think one of the things that I was hearing in that too is like, it's not just about like content, knowledge of facts or whatever, although obviously that's important, but like it's about access to a process. And I think it's the process that's translatable across all contexts. So if it's a process of knowing, for example, that how to make space to have conversations, in that all of this work is always relational, all of this work is like, I don't know, kind of going off the deep end, I guess, of my description there, but like that was really what I got from Reg today, was like, it's not just about the content, the process is translatable across people.
Yeah, and I think that's embedded in the incentive of a dialogue process, is that nothing's final here. So let's go back to the larger group, unless Dr. Brownlee wanted to add anything. Then, okay, let's go back to the large group.